Weight loss and thrombocytosis. Letter of referral to General Medical Outpatient Clinic. Dear Dr. Mr. Francis Green, aged 63 years. This man has lost 1 stone, about 6 kilograms, in weight, which is not due to dieting, and he has an abnormal FBC. He rarely troubles doctors, but has come to the surgery over the last year because of angina, for which I have given him bisoprolol and a glyceryl trinitrate spray to good effect. He has worked as a publican for 30 years, but keeps to 25 units of alcohol per week. His FBC shows hemoglobin, HB, 12.2 g/dl, normal range 12-16.5, mean corpuscular volume, MCV, 91 FL, normal range 80-100, platelets 964 × 10^9/L, normal range 150-400, and a white cell count 10.6 × 10^9/L, normal range 411, with neutrophils 6.4 × 10^9/L, normal range 27. I am worried about these abnormalities, please investigate. Yours sincerely. Introduction. Thrombocytosis can be a feature of systemic disease, which needs to be excluded before a diagnosis of primary thrombocytosis can be established. Secondary thrombocytosis rarely causes thrombotic problems, even when the platelet count is over 1000 x 109/L, whereas primary thrombocytosis is associated with thrombotic episodes. Thrombocytosis can be divided into primary, essential, thrombocytosis or myeloproliferative disease, and secondary, reactive, thrombocytosis caused by 1. Malignancy, 2. Infection, 3. Inflammation, 4. Hemorrhage, 5. Hyposplenism, 6. Iron deficiency. History of the presenting problem. Most medical histories naturally begin with a discussion of the main symptom, identified by the patient. However, in this case there are few symptoms mentioned in the referral letter, only the very nonspecific one of weight loss and angina, which is clearly not the reason for an opinion being sought, although it must be briefly discussed. In conducting a careful functional inquiry, you need to explore both potential causes of the high platelet count and possible complications arising from the thrombocytosis. NB. Primary, essential, thrombocytosis is a diagnosis largely made on the basis of exclusion. Do not make it too readily and miss an occult malignancy. Causes of his thrombocytosis. Weight loss. The loss of weight needs to be explored in detail. Has the patient actually weighed himself, or is the estimate of 1 stone a guess? But in the context of this case, this symptom obviously suggests malignancy, so check carefully for clues. General, anorexia and night sweats. Respiratory, cough, hemoptysis, and chest pain. Abdominal, nausea, dysphagia, vomiting, indigestion or abdominal pain, and any change in bowel habit or rectal bleeding. Genitourinary, lower urinary tract symptoms and hematuria. Alcohol intake and smoking. Is the alcohol history correct in this case? It is common in routine clinical practice for patients to give an underestimate of their alcohol consumption on first inquiry, and in PACES for the letter of referral to do so. Point out the issues connected with this to the patient and then ask directly about his drinking habits. Sometimes a high alcohol intake can cause this sort of problem with the blood. Are you a heavy drinker now, or have you been in the past? How many drinks do you have now on a typical day? And, possibly, when you were drinking more heavily in the past, how many drinks would you have then? Hepatoma may arise on a background of cirrhosis. Smoking predisposes to many malignancies. If the patient is a smoker, then find out for how many pack years. If not, then ask if he has been exposed to passive smoking, very likely given his occupation, and for how long this has occurred. Complications of thrombocytosis. Evidence of thrombosis or ischemia should be sought. The man's angina may be exacerbated by his thrombocytosis, although it is unlikely to be the sole cause. But how bad is it now? Has he had any other thrombotic or ischemic symptoms? Ask in particular about headaches, transient ischemic attacks or strokes, paresthesia in hands or feet, and claudication or foot pains. Thrombocytosis can also cause bleeding and bruising due to abnormal platelet function. Has he been to the dentist recently? NB. Thrombocytosis typically causes arterial rather than venous thrombotic events and is also associated with bleeding. Other relevant history. Consider the different causes of thrombocytosis as you proceed. Occult infection. Consider tuberculosis. Has he been exposed to this? Has he done any foreign travel? Inflammation. Does he have arthritis or any other chronic inflammatory process? Hemorrhage or iron deficiency. These seem unlikely here with a normal HB and MCV. Hyposplenism. Has he had his spleen removed? If this was done many years ago, the patient may have forgotten about it, and in PACES the surrogate's briefing note may say do not mention this unless asked if you've had any operations. Plan for investigation and management. FBC and film. It is important to confirm the initial abnormalities with a repeat sample, which will also identify any trend in the platelet count. In primary thrombocytosis, the film will show a variety of platelet sizes and shapes, and megakaryocyte fragments may appear. In contrast, in reactive thrombocytosis, platelets are plentiful but generally normal in size. Inflammatory markers. Plasma viscosity and C-reactive protein may indicate inflammation. Other blood tests. Biochemistry and liver function tests may indicate liver or kidney problems. Autoantibodies may indicate autoimmune rheumatic disorder. A low serum ferritin would indicate iron deficiency. A cancer marker screen is of variable utility. They are best used for monitoring established cancer rather than as a screening tool, but using them to obtain an estimation of alpha-fetoprotein could be justified. CXR. Look for malignancy and infection. The patient should be reviewed when the results are available, with further investigation dependent on the preliminary findings. Further discussion. In the absence of secondary causes, a bone marrow aspirate intrafine may indicate increased myeloid and or megakaryocytic activity. Cytogenetic analysis will exclude chronic myeloid leukemia as a cause of thrombocytosis if there is no Philadelphia chromosome. If the patient asks whether cancer is a possibility, this should not be denied, but he must be assured that nothing is certain until the investigations are completed. Treating secondary causes often improves the platelet count, but where there is a thrombotic risk, e.g. angina, aspirin will offer some protection. In primary thrombocytosis, cytotoxic therapy needs to be considered in addition to aspirin.